Hello, everyone. Thank you for joining today. We have another episode of Principles of Surgery online course, and I'm happy to introduce you to our today's speaker, Dr. Robert Patterson. He's a professor of surgery at Brown University, a vascular surgeon, and a past president of New England Society of Vascular Surgery. And today's lecture will be on the management of arterial disorders. Thank you, Dr. Patterson, for joining.
Thank you, Ali, for this invitation. It's quite kind. It's not a very narrow or focused topic, but the whole management of arterial disease, and I hope that I can do some justice with it in 60 minutes. And I need to start moving my slides. There we go. I have no disclosures. I want to really thank Jorge Flores, who's one of our second-year medical students at Brown, for having helped me pull this together over a short period of time, and his efforts were very useful. So thank you, Jorge. So the format for today is that I am planning to review 3 topics, and I will review each one based on trying to extract some guidelines from both the European Society and the Society of Vascular Surgery in America based on consensus documents and lots of references. And there will be these references at the end, which I think will be useful for people to refer to if they have additional questions. All of these guidelines are very voluminous and very well done. I'm also, at Ali's request, going to add a personal approach to each topic, which maybe a little unorthodox, sometimes usually fairly mainstream, but just to give some technical ideas and some things that I think are important. So we're going to talk about extracranial carotid artery disease. We'll talk about aortic aneurysm disease and its management, and then peripheral arterial disease, including both claudication and limb-threatening problems. So just as an overview before we get into those topics, any patient that has atherosclerosis, whether it's coronary, cerebrovascular, peripheral arterial disease, there's sort of a mainstay of primary therapy for those patients. And medical therapy is probably more important for the overall population of patients with atherosclerosis than any of the interventions we do, which I know is heretical for surgeons, but I think it's true. So management of hypertension with a very tight target, if possible. We like to see diabetes with hemoglobin A1Cs under 7. High-dose statin therapy, although a target of 70 is good, if somebody has active vascular disease, higher doses may be appropriate, even in the absence. Smoking cessation is something we all struggle with, but is obviously critically important. And then aspirin, whether it's 81 or 160 or 325, is a mainstay of care. And whether the other antiplatelet, dual antiplatelet agents factor in is a focus of different disease processes and guidelines. So if we talk about extracranial carotid disease, there are many causes of stroke, but embolic disease from the carotid artery are representative for probably 1 in 5 of the strokes we see. And the risk factors are typical for atherosclerosis. And these are, I'm sure, pretty evident in your patient population as it is in ours. And modifying these risk factors, again, going along with the first slide about medical therapy, is probably the most important aspect of management of extracranial carotid disease. So if you look at imaging, any patient that presents with a TIA or a stroke should have, at the very least, a duplex scan to see if it could be the result of atheroembolism from the carotid, or is there another etiology. And CT angiography is important, particularly for stroke patients in selected centers where it's possible to do advanced interventions to limit or resolve the stroke. And this is a huge difference over the past 30 years or so, when we are now treating stroke like heart attacks and doing rapid interventions and actually saving some brain and limiting some of the risks. Some selected asymptomatic patients ought to be looked at and screened with duplex scan, depending upon your philosophy and the opportunities to intervene. And the interventions, as you know, carotid endarterectomy is a durable procedure that's been around since the 1950s. The results have improved substantially over the years, and it has a good long-term performance. Transfemoral carotid stenting, going through the groin or now sometimes through the radial artery, is a procedure that has gained some traction over the past 20 years, and transcarotid artery revascularization has been studied and become very popular, at least in this country, over the past 5 years, and is now beginning to challenge endarterectomy as being at least a potential equivalent of that procedure. So when we talk about interventions, for lesions that are not symptomatic, there's no justification at all for support based on the society guidelines for lesions that are less than 60%. And most of us would argue that if you're going to intervene on asymptomatic disease, it probably should be 80% or greater stenosis. The stenosis represents more of a plaque burden and possibly plaque risk than it does necessarily perfusion issues. For patients that are symptomatic, if there's a less than 50% stenosis, generally medical therapy is superior to intervention. There are rare instances with ulceration in a plaque that could change that, but for the most part, symptomatic disease that's less than 50% should simply be a more focused attempt at improving their medical care. So if we look at symptomatic patients, carotid endarterectomy is as good, is the best, potentially equivalent to TCAR, and outside of very focused clinical trials, we don't have that data yet. But clearly the outcomes are improved over carotid artery stenting with regard to neurologic issues. And for most of us would consider them to be the primary approach to intervention. Transfemoral carotid stenting or TCAR are certainly well accepted for patients that are of a high risk anatomy, somebody that has a tracheostomy or a spit fistula, has had radiation therapy that may make the surgery more challenging, or lesions that can't be surgically accessed, although those are rare. People with really substantial cardiac risk, with active heart failure, unstable angina, it may be that those patients' risk is significant enough that the risk of stroke isn't as much as the risk of surgery, and maybe just medical therapy. So we don't do any interventions at all for somebody who comes in with a truly disabling stroke, the new Rankin scale of greater than 3, because there's not really much benefit to salvage, and you can clearly make those people worse. If somebody has a TIA or a non-disabling stroke, the current recommendation is to treat the appropriate person within a window of 48 hours and less than 2 weeks. The risk of recurrent events and worsening of the disease is pretty significant early on. So we tend to be pretty aggressive about approaching those things. And again, these are still practice guidelines from the societies. In somebody that has crescendo TIAs, that's having multiple TIAs despite perhaps anticoagulation and aggressive blood pressure management, urgent CEA can be considered earlier than 48 hours. That's not a common presentation, but we've all taken care of a few of those in our careers. And there's still support for carotid endarterectomy for lesions that are not causing symptoms, that are greater than 70 or 80% in people that are otherwise fit for surgery. The CREST-2 trial right now is completing, and they're trying to answer the question about whether there's a subset of people with asymptomatic lesions that provide benefit as opposed to everyone that has that. So we talk about technique. For carotid endarterectomy, there's sort of 2 different camps. I'll present a little bit of a third later, but the first is the traditional carotid endarterectomy, which is a lengthy arteriotomy extending well into the internal carotid past the end point, and providing patch closure, because that tends to substantially reduce the risk of restenosis, as has become the standard, at least in this country. There are rare instances where a primary closure is appropriate, but that tends to be not the acceptable standard today. And then eversion endarterectomy, which consists of transection at some different level, depending upon your approach to it, of the carotid artery and providing an eversion with a carefully tapered endpoint. The proponents of this suggest that it's quicker, that it has less restenosis, and does not establish any prosthetic patch or any issues. The standards also suggest that protamine reversal of heparin, which used to be thought to be contraindicated, is clearly not shown that way, and it reduces bleeding complications. There's a variety of cerebral monitoring techniques, which include stump pressures, which is measuring indirect evidence of blood flow in the brain, EEG, doing patients awake under local, or people who always shunt the patient. All of those are acceptable and don't seem to have a significant difference in outcomes. So it's pretty much surgeon preference. And then again, primary closure is not something that that tends to be considered for most patients. When we talk about carotid stenting, again, just to review some of this, the difficulties with transfemoral or even transradial carotid stenting revolve more around the arch of the aorta and access to the internal carotid, because some patients have significant atherosclerotic burden, can have complications from this. And again, in a very skilled proceduralist, these procedures can be relatively safe, but the arch seems to be the most daunting problem with carotid artery stenting in a traditional fashion. On the TCAR device that has been established over the years depends upon flow reversal with a shunt and a filter that takes blood from the common carotid artery with a surgical cut down into the venous system to reduce any embolic complications during the course of the angioplasty. Some form of protection with transfemoral, it should be a filter. With TCAR, with transcarotid, it's part of the system itself. The protection needs to be done prior to angioplasty, which is done prior to deployment of the stent. And everyone seems to agree that post-stent angioplasty carries with it a greater risk of what we call cheese grater embolization of plaque and should be avoided. So when we look at the most standard studies that have looked at carotid endarterectomy versus transfemoral carotid stenting, when you're trying to decide what your approaches should be, stroke at 30 days clearly favors carotid endarterectomy over carotid stenting, and that's held true in the overwhelming majority of studies. On the other hand, carotid endarterectomy does have a higher risk of myocardial events, either those that are measured simply through chemical troponins and EKG changes, or true significant events. My own bias and the bias of some is that strokes tend to have a greater patient-affected debility at a year or 2 years than do myocardial infarctions, but still myocardial infarctions are not to be ignored. And this can help you decide what the risk of your patient is regarding the approach that you want to take to the procedure. So my approach. So I'm very selective for asymptomatic patients. I've been involved in the CREST-2 trial, and that has emphasized so much the medical management, and we don't have the results. It'll be about 2 years or 3 years before they're published. But I suspect that we will narrow the focus on patients who deserve surgery for asymptomatic disease. I use a different anesthesia. A lot of people use endotracheal, some use cervical block or local. I tend to combine these with a laryngeal mask airway, which I think causes less hypertension and tachycardia, less hemodynamic instability, and combine that with a superficial cervical block for both pain control and also to minimize the hemodynamics that we see with endotracheal tubes. So I found that over the years to be a very satisfactory way to provide anesthesia for my patients. I've stopped using the traditional incision, which you see on the left, which is a mastoid process to sternal notch incision. provides great exposure, but when they heal with very disfiguring scars in some patients. But if you follow Langer's lines and do a curvilinear approach, you can hide most of that incision with those Langer's lines and it disappears. And although we all agree that we're not there for an incision, we're there for stroke prevention, patients still care about how things look when they're done. So I tend to use a lot of scalpel dissection, which is, I think, a dying art, but I think that it provides you atraumatic plane exposure and scissors rather than doing cautery dissection. I use bipolar electrocautery because once you get down to the cranial nerves, I don't want them to arc and have a complication from that. A former faculty member of mine said that with this no-touch dissection, that basically you're dissecting the patient away from the carotid artery. The idea being that you minimize the manipulation of the bulb until you have heparinized the patient and clamped so that you minimize the risk of embolization. I use stump pressures. I don't have a slide or something for that, but it's a way of looking at potential collateral circulation. And I also use cerebral oximetry, which may be available, which helps you look at the hemispheric perfusion in a transcutaneous method. And the combination of the two is how I decide to proceed with selective shunting. If somebody's had a recent stroke, I tend to have a very low threshold for shunting those patients, and I almost always shunt them. Although I do tend to look at stump pressures and cerebral oximetry just to know where they stand if we have shunt problems and issues. I do a modified eversion technique, which is a little different than a standard eversion in that you don't transect the carotid. And if you have any issues with it, you can convert to a traditional patch angioplasty. If I know I'm going to shunt, I just do a traditional patch angioplasty so that I can put the shunt into healthy vessel and minimize the ischemia time. I do a duplex scan in the operating room to ensure that the technical performance is good. This is controversial, but I think most of us that do it feel comfortable that we can better identify any potential technical factors with the reconstruction that could cause it to fail. I use protamine. I only close with a running platysma closure, and I put staples in the skin and remove them on the first post-op day. I try to keep the blood pressure over a mean of 60 and less than 160 systolic in the post-op period. So this is a modified eversion technique. As you can see, there is a typical longitudinal arteriotomy performed, but it stops short of the end of the bulb. And then by teasing out the plaque, this is probably the best example where you have that nice separation. Once you develop your plaque to muscular layer separation, you can tease it out and carefully establish where the endpoint is and see the endpoint under direct vision. You just mobilize the internal somewhat. And the duplex scan lets me confirm that I do have a decent endpoint and that I haven't created a flap at the end. If I have, which I haven't for years, but it does happen, then I simply reclamp the patient, extend the arteriotomy, and do a traditional endarterectomy, which is certainly an acceptable primary approach. So let's talk about aortic aneurysms, which are certainly a concern for everybody. A ruptured aneurysm, 80% of them are fatal when they occur. They don't make it to the hospital. Those that come to the hospital, their outcomes aren't nearly as good as people who have elective procedures. Their mortality is higher and morbidity is higher. Obviously, you can see this on ultrasound. You can find it on CAT scans. Arteriography is a poor way to look at the aneurysm itself, but is useful for anatomy. So if we talk about screening, I mean, intuitively, you'd think that looking for aneurysms would help reduce the risk of rupture and that this would be a very good thing to establish. Many societies are not in agreement with their national health services, and most of us suggest that high-risk populations, and there's no specific definition for high risk, but a strong family history is certainly a high risk, I believe, and a smoking history is an additional risk. And the other typical atherosclerotic risk factors are certainly taken into account. So those patients, most of us would consider to be reasonable to screen with ultrasound. At least in the US, it's hard to come through the emergency room and not get a CAT scan. And a lot of aneurysms are picked up asymptomatically when they are, when the patient's having imaging for another indication. And certainly CT gives you detailed anatomic information that you can't get, or it's difficult to get with a duplex ultrasound. So it's very well established that the guidelines suggest that a male with a 55 millimeter or less, or a woman with a 50 millimeter or less, should not be considered for intervention. And now the current recommendation for iliac aneurysms is 40 millimeters, which used to be 3 to 3.5. So that's expanding. And the most recent SVS risk assessment for ruptures is considerably more conservative than previous estimates. And so the published risk for them is that the rupture risk is extremely small, certainly less than 2% for small aneurysms of less than 5.5. When you get to 6 centimeters, it increases modestly, a little bit more for 6 to 7, and then significantly over 7. And I think we would all certainly be concerned about aneurysms of that size. But taking these newer risk factor publications, a group recently did a Markov model, which is a statistical analysis, and you can't really provide complete clinical care from just a statistical analysis, but I think it makes us begin to think or rethink what we do. And they said that in their Markov, a 60-year-old woman who presented with a 5-centimeter aneurysm, they suggested that following them to different age for a larger aneurysm would be appropriate. So they suggested a 6.2 centimeter for a 60-year-old woman, a 70-year-old woman for a 7-centimeter. Again, this is based predominantly on risk both of endovascular and open. It's the reference is at the bottom of the slide, and it's a very interesting concept. And for men, it was even more, I don't know if I want to say alarming, but certainly surprising, because their models suggested that 6.9 was the appropriate size threshold. And that, again, calls into question some of the original thoughts, but the original numbers of 5 and 5.5 were based on an estimate of what would be safe and never have been confirmed in some of the prospective trials, because nobody's really gone to the next level. So what are the options? Well, basically, it's fairly straightforward. Aortic aneurysm grafting has been performed for 70 years and is a very durable and extremely good approach to aortic aneurysms in terms of eliminating completely all of the diseased vessel, and appropriately should be into as healthy a vessel as you can establish. Endografting is something that has been very popular for at least 25 years, is overtaking open aneurysms as the primary approach, but clearly has its limitations long-term in terms of potential for graft failure or ongoing difficulties with endoleaks. So, the consensus, as I can interpret it from the societies, is that EVAR is good for favorable anatomy, again, trying to stay within the manufacturer's recommendations, and for patients that have a reasonable life expectancy. I mean, the average vascular surgery patient. But somebody that comes in who's quite young, that has favorable anatomy, or maybe unfavorable anatomy for an EVAR, but certainly something that could be done open, may be better served with an open repair. And I think that for younger patients, many of us become more conservative about offering EVAR and tend to offer open repair because at the current time, regarding durability. And the population that is the most struggle are those patients that have limited life expectancy, people that are quite elderly with associated comorbidities, or even younger patients with severe comorbidities. They may survive an aneurysm repair, but a lot of the data suggests that you have not improved their longevity. So people tend to be very anxious to have aneurysms fixed, but if it's not going to improve their life, and in some cases actually make their quality of life worse if there's complications, they may choose to avoid repair in that setting. So again, these are standards of surgical approach from the societies. The proximal anastomosis should be as close to the renals as possible. Many years ago, people would tend to just fix the aneurysm itself and leave a long infrarenal segment, and it was shown in multiple studies that that resulted in ongoing aneurysmal degeneration and often required either additional open operations or today more advanced endovascular. One of the internal iliac arteries should have perfusion maintained. That reduces the risk of colonic ischemia. Whether you do a transabdominal or a retroperitoneal approach, again, based on the guidelines, nobody has established one superiority over the others. In some hands, retroperitoneal approach is better for more proximal control of paravisceral and pararenal aneurysms. A midline or transverse procedure is both acceptable. Midline may tend to have more hernia difficulties going down the line, which is one comorbidity associated with open repair that can be very significant for a patient. With regard to the approaches of the societies in endovascular repair, they all emphasize the need for really strict adherence to the IFU. If you stray from the instructions for use, and most of us do, but if you stray from them, the risk of late complications or even early complications from standard endovascular infrarenal grafting go up significantly. So there's a strong recommendation for that. Most aneurysms can be fixed under local anesthesia for endovascular repair, or laryngeal-mastic airway if it's going to be complicated and the patients are going to be uncomfortable in moving during the procedure. But local anesthesia is a very effective way to manage these, particularly for high-risk patients. And most of us have graduated to ultrasound-guided percutaneous access, which also reduces some of the morbidity of this procedure. Something that is never emphasized, but is emphasized in the guidelines, is that radiation safety, particularly as our patients and we are being subjected to more and more medical radiation, is really critical, particularly as the endovascular grafting can become a little bit more complicated in some of these situations. And finally, there's some concern generated in the society approaches that the newer generation stent grafts are aiming for lower and lower profile, trying to do more with less, and it's possible that over the course of 8 to 10 years, some of these grafts may not have the durability. So if you're using a graft that has a 10 to 15 year registry follow-up with excellent results, you can be confident. But newer grafts, you may want to be sure that you're doing it within a registry so that it's possible to examine the risk profiles. There have been a couple of grafts that have shown that at the 5 and 10 year mark, they have a higher failure rate than others. And that's why registry use of the grafts, putting them into a registry, is important to understand their performance. So, how do I do it? So I've tended to gravitate to the newer rupture assessment, maybe not as aggressive as the Markov model, but when I have a frail or high-risk patient, I don't worship the 55 millimeters, but I will observe them to a larger size, or even have the difficult discussion about the possibility that their life is not going to be extended by aneurysm repair. It could be affected negatively, and it may be that they need to consider the possibility of not having anything done. It's a difficult concept to grasp. People seem to accept stage 4 cancer more than they would an aneurysm as the end of their lives. But in some patients, it's clear to all of us by looking at the patient that their post-operative course might be challenging and might not be in their best interest. Open repair for younger patients, I still feel very strongly about. I think that the durability of open repairs is even in just anecdotally in a practice where I'm seeing patients back 15, 20 years after an aneurysm repair who are doing great, and the occasional patient after an EVAR that we're chasing some type of endo leak. And I also recommend open repair in my own practice for people who don't fit the endovascular repair, particularly people with hostile necks and pararenal aneurysms. In my own practice, based on the nature of where I practice, I send thoracoabdominal aneurysm patients to a specialized center, and particularly patients who need a complex endovascular repair with fenestrated grafts and the more customized grafts that people are doing, as well as physician-modified grafts. In my own practice, I prefer to send them to somebody that does many of those, because I think that the outcome from them is better than thoracoabdominal open repair in those people's hands. But if you don't see enough of them, the very careful details and the equipment involved suggest that maybe a specialized center is the most appropriate place. When I do open repairs, I do an epidural for perioperative pain, although sometimes it doesn't get used in the operating room itself. And I do general anesthesia for the case, obviously. I have found a bilateral subcostal incision to be the most appropriate way for me to manage patients, particularly with pararenal aneurysms. It gives you excellent exposure for the paravisceral aorta. And you can access the entire aorta-iliac system. You can extend it into the flank to get a little bit more distal exposure if necessary. And for me, the most important piece of this, well, two important pieces. One is that I find that they have less postoperative pain because the incision moves with them. If you have a midline incision and you take a deep breath, it kind of tugs away at the incision and causes much more pain. That's an anecdotal observation. And more than anything, there's many fewer hernia recurrences in patients with a transverse incision. And if they do occur, they're less likely to cause worrisome hernias that can cause bowel obstructions. It's very clear in the literature that patients with aneurysm disease have a propensity to all types of hernias, both primary hernias such as diaphragmatic or groin hernias, but a significant increase in the risk of wound hernias compared to patients who have the same operation for occlusive disease, don't have the same amount of hernias. So I pay a lot of attention to that, and that's why I favor the bilateral subcostal approach. For exposure, I think it's really, I have started dividing all of the tissues, the subcutaneous tissue, as well as the rectus musculature and the flank musculature, using either a ligature or a harmonic scalpel, because I found that that substantially reduces some of the post-op lymphatic leak you get with these transverse incisions. The exposure needs to be extensive. You don't want to be in the unfortunate situation of having exposed part of the aorta, put it on your clamps, and then find that you really aren't in healthy enough aorta to sew to, and you need more proximal control, and you haven't established it already. So very extensive exposure is important. Self-retaining retractors are, I consider them almost a necessity today, as opposed to the 30 years ago, 5 medical students standing around with retractors. Self-retaining retractors provide excellent exposure. In patients that need renal artery reconstruction, I find that, or significant pararenal aneurysms, I find doing a Cattell-Brash maneuver and bringing the small bowel up rather than tucking it to the right as we traditionally do provides incredibly good exposure for the whole paravisceral aorta. And that's something I think should be considered. Occasionally, I will divide the left renal vein if I can see that I'm going to have difficulty with the proximal neck, and I don't want to be fighting with a vein after I mobilize it. Usually, I will mobilize the vein by dividing the gonadal and the lumbar veins, and occasionally, but not generally, the adrenal veins. But if you're planning to divide the left renal vein, you need to make that decision early to allow the collateral venous drainage to decompress the renal vein. And in those cases, people have not shown any significant deterioration in renal function as long as you maintain the collateral circulation. If I'm doing simply mobilization of the renal vein, to me, the most important thing is identifying not just the left gonadal vein, but the lumbar vein. Gonadal vein is easy to identify and ligate, and the lumbar vein is right there usually. I've seen situations where the lumbar vein has been either inadvertently divided or not adequately controlled, and those kind of venous bleeding is very difficult to control, a real problem. Similarly, I try to get my iliac control beyond the bifurcation of the iliac to avoid getting circumferential control of the iliac where the right renal, where the left renal vein comes across. That's an area that if you injure it, the repair is very daunting. We have a saying in my operating room that arterial bleeding scares amateurs and venous bleeding scares professionals, because a venous bleed, especially behind the artery, can be very challenging with a substantial amount of blood loss. So I'm really meticulous about trying to avoid that injury. I reimplant the inferior mesenteric artery based both on the preoperative imaging, although if it looks like it's a dominant inferior mesenteric artery, you should suspect associated superior mesenteric artery disease, and you need to be cognizant of that if it looks like you've got a very large IMA, but also mostly on intraoperative assessment. After we've I control the IMA with a Yassergill clip or a small clamp, do my reconstruction, and then assess the IMA for back bleeding. If you have excellent back bleeding, I will ligate it. But if it's desultory, I will reimplant it using a Correll patch into the graft. I'm very meticulous about trying to make sure that the aortic sac and other retroperitoneal tissues are covering the entirety of the graft. And I try to make the fourth portion of the duodenum an intraperitoneal organ so that it is definitely separated from the graft, because the most devastating complication that anyone can deal with is an aortoduodenal fistula or infection of the graft from not adequately covering it. Postoperatively, I take the nasogastric tube out when I extubate the patient, but I don't feed them until they start passing gas. There's a big push to use clear liquids and try to do advanced recovery. I haven't embraced that yet. I think that an extra day of not being taking food is small to cover, rather than having somebody vomiting the post-op period and requiring a longer period of time to resolve an ileus. Try to get them out of bed in the first post-operative day if they don't have groin incisions. The most common cause for mortality and extended morbidity in the aortic population is the term failure to rescue, not being able to recover from renal problems, from colonic ischemia, from myocardial infarction. And staying vigilant and looking out ahead of time for these potential complications is the most important thing to reduce the mortality in your population. I have a very low threshold for doing sigmoidoscopy in a patient who's just not looking right. A patient who's requiring substantial amount of fluid but isn't showing any evidence of bleeding is somebody that's at great risk for having colon ischemia. They should have a sigmoidoscopy. We have a policy that everyone that is operated on for rupture has a sigmoidoscopy on the first post-operative day as a mandatory policy, because that's a substantially higher risk in that population. Look for compartment syndrome. If there's been an extended ischemia period, occasionally these patients will develop compartment syndrome, and we don't think about it often, and it's something that should be vigilant in the first 24 to 48 hours. And finally, the perioperative fluid management and pulmonary care is critical, again, to avoid complications that you can't get ahead of if they occur. Ruptured aneurysms, a thoracoabdominal CT will let you figure out whether it should be an EVAR or an open approach. If a patient's unstable, they can go directly to the operating room, and sometimes you can make this decision based on arteriography or do open repair as your standard for those patients, which is my preferred approach. But a patient who is unstable and you have imaging and the comfort level and the equipment to do it, EVAR is clearly the current way to go for managing ruptured aneurysms, sometimes with using balloon occlusion of the aorta to establish stability and also help place the EVAR. Certainly stable patients, EVAR is a much preferable way if they are anatomically suitable. And this is an place where you can cheat a little bit on the instructions for use, because again, the morbidity of open repair is more significant. When I do open repairs, I always prep and drape prior to intubation, since once the patient is induced, they can lose some of their blood pressure that's being held by their pain and their discomfort, and suddenly you end up with a patient who is crashing that wasn't crashing before. So I get them all prepped and draped, and then I make my incision at the time of intubation. Basically at the same time. I use a midline incision for open repair because of the rapidity of the procedure. And then at the diaphragmatic hiatus, you can do finger dissection of the aorta and apply a clamp in a relatively short fashion. And that then stabilizes the patient, or should stabilize the patient, and allows you to open the retroperitoneum in a more traditional fashion infrarenally. And the clot has often done the dissection for you, and you can place your clamp down either just below or above the renal arteries, depending upon the anatomy. And then that just turns into a standard open repair when you remove the diaphragmatic clamp. So let's talk about peripheral artery disease, which obviously comes in a whole variety of degrees of concern. So the diagnosis of it should be familiar to most of you. Obviously, history and exam, which is critical. And if you do a history and exam and an ankle brachial index, you can very firmly establish the presence of peripheral artery disease and its degree of concern. Ankle brachial index, as you are aware, is taking your highest brachial artery pressure of either arm and the highest of the two pressures in the leg, the anterior tibial at the dorsalis pedis and the posterior tibial behind the malleolus. And you do the ratio, which should be greater than 0.9 for a patient that's normal. One that's non-compressible or greater than 1.4 suggests calcification of the tibial vessels, which is frequent in diabetes and renal failure, and is also considered an abnormality. And at the very least, these abnormalities demonstrate an increased risk of stroke and heart attack. Then you have the categorization of patients into patients who have been screened, or you have a suspicion for, you don't feel pulses, that have no symptoms. And those patients, again, should be back in the medical therapy arm. Patients with claudication, which is pain in the calf or the thigh with walking, relieved with rest, are a non-threatened population. And then chronic limb-threatening ischemia with rest pain, which is pain awakening from sleep, usually in the toes or the forefoot. It's relieved by dropping the leg over the bed, or a patient that comes in with gangrene or tissue loss. Those patients are at high leading to amputation without intervention. Physical findings include dependent rubor and pallor with elevation. So an ankle brachial index of less than 0.4 or a toe pressure of less than 30, where you do pressures with a cuff around the toe. Both of those are also associated with the more threatening chronic limb-threatening ischemia. And again, here's another cartoon of how to do an ankle brachial index. And it's a little bit more challenging than people think, but the patient should be lying down, and you should get these and sometimes measuring them 2 or 3 times to be sure you're correct. So this is a bit of a busy slide from the European Society of Vascular Surgery for asymptomatic and claudication management, looking at a population that are not at threat. Really, the most important part of this comes all the way down to the very last. If you look at, there's 3, 6, there's 7 different pieces to this puzzle, trying to establish the diagnosis, figuring out how the risk factors for that patient, having them controlled with medical care and exercise, and not until you get to the point of failure of all of these problems in a good risk patient should you consider intervention. And that's a fairly standard recommendation across the societies. On the other hand, patients presenting with signs of significant ischemia are at greater risk for having problems that can lead to amputation. And this has led to a very well-established, and not confusing, but complex way of grading wounds for patients that come in that have a significant ischemia, and also establishing ischemia itself. So the 2 classifications that I think are important here is wound ischemia and foot infection. And just go through a few of these slides. They go, again, these are well published, and I understand this talk will be available. So if you really want to delve into it, these are available. But it goes from having somebody that has no foot wounds at all to somebody that has such extensive foot wounds that they may not even have a reconstructible foot. And that grading goes from 0 to 3. When we get to the ischemia part, the blood flow part, again, 3 grades based on both ankle brachial indices as well as toe pressures, which are, the toe pressure is probably more reliable, but is not frequently done. Certainly in a patient population with non-compressible ankle brachial indices, and toe pressure should be established. And again, the gradients go from somebody that has minimal ischemia, if any, to more modest ischemia that normally be associated with claudication, to somebody that has profound ischemia. And then finally, the infectious side of this, also similar to the others, graded 1 to 3, from somebody that has no infection to something that's very minimal, such as a small ulceration, to a more significant infection involving osteomyelitis or significant erythema. And finally, somebody that presents with severe infection. You all have probably seen somebody coming in with a gangrenous foot who has evidence of systemic inflammatory symptoms from that. And the obvious thing for that is source control. And then the next staging system is what they call the global limb anatomic staging system, or GLASS system. And this is just a representative slide, but what they try to establish is anatomic impediments to direct axial flow, meaning the idea behind foot salvage in a patient that requires it from a vascular reconstructive perspective, either minimally invasive revascularization or open surgery, is to establish inline flow all the way directly to the foot. And so the GLASS anatomic system is attempting to categorize what is involved with establishing inline flow. Is it something that's relatively simple and straightforward, or is it a complex multi-level procedure? And so they analyze this in several segments, and particularly in the popliteal and tibial segment, because that's the most controversial area for intervention. So using these 2 segments, you first establish the patient indeed has critical limb-threatening ischemia. They have ischemia as part of their problem, and it's not just a diabetic foot wound with normal pulses and normal perfusion. You need to have good angiographic assessment. CTAs, MRAs, duplex scan are not enough to truly establish in every patient the complexity of their anatomy. And you have to figure out what they call the target artery path. How are you going to get direct flow into the foot? And then you grade the degree of disease and the symptoms, and then you add in the Wi-Fi score. And between the 2, and again, you have to go to the recommendation in these articles to get a real understanding of it. But basically, balancing your GLASS score and your Wi-Fi score can lead you to help establish whether a percutaneous with balloon and stent kind of approach is the appropriate approach, or is an open surgical reconstruction, or for the occasional patient, is primary amputation something that might be better served rather than a likely failed reconstruction. And this is the, again, the complex algorithm that people pursue, and it lands into three different areas, okay? Primary amputation, or what we call palliative wound care. I have elderly, very morbid patients who have a very minimal wound that is not of great significance. And between wound care centers, my practice, and podiatry, we're able to maintain their wounds in a non-threatening way and not put them through the morbidity of a procedure. That's a rare patient, but that's the occasional. And a primary amputation would be somebody usually who has a non-salvageable foot or a completely non-reconstructible arterial status. High-risk patients, try to pursue endovascular intervention because of the morbidity. But a standard risk patient, you can decide whether it should be endovascular or open based on a whole variety of factors. Some of the new US trials tend to favor open reconstruction as a primary procedure, certainly if they have good conduit, but again, those aren't universal. And these guidelines here try to combine the Wi-Fi scores so that patients who have significant ischemia and wounds have a high benefit from revascularization. People with no wounds don't have any benefit, or with no ischemia, I should say. And patients with a lesser wound or no significant ischemia get no benefit from revascularization. And then you can use this also, the choice of revascularization in terms of leading to open or endovascular revascularization. Usually, the more severe the tissue loss and the ischemia, the more it favors an open repair. So just to get into my approach again and give you some opinions, claudication, I'm extremely conservative, but I think it's held up over the years. And I think that our societies are becoming more and more firm in the need for maintaining these more conservative patient-based approaches. So I think a patient should have a minimum of 3 to 6 months of exercise therapy. It's preferable to do in a supervised setting, but if that's not available, if you have an educated patient, you can discuss with them how to pursue exercise at home, generally with very good results. I do primarily stenting, but occasionally open repair for aortoiliac disease that requires intervention for a patient who's failed exercise therapy and is clearly debilitated. There's a lot of interest in common femoral end arterectomy isolated with profundoplasty for patients with claudication and multi-level disease, as they seem to be the ones that are least likely to benefit from conservative therapy. And more importantly, they're very straightforward, durable operations that can take somebody from a limb-threatening position to a more manageable claudication situation. And finally, patients that have isolated infrainguinal disease, they have exclusive exclusivity with modified risk. I'm sorry for 1 second. Kurt, I got to talk to you another time. Is emergency? Sorry. Exercise, I really push in patients that have infrainguinal disease. I think the long-term consequences of seemingly simple procedures with angioplasty, stent, advanced endovascular techniques, the 2-year performance just isn't there. And I am very strong about not intervening in that population. So for chronic limb-threatening ischemia, most important thing is somebody comes to your emergency department or your office and they have a significant infection with systemic signs. They need immediate attention with drainage and source control and debridement of any infected tissue. And then establishing whether ischemia is a major component of that is important, and what the approach should be. Obviously, inflow has to be a directive first. And as I said, for somebody that has rest pain but no tissue loss, frequently a femoral endarterectomy and profundoplasty gets them out of a limb-threatening range with a relatively minimal procedure with excellent durability. For tissue loss, I think, along with the glass criteria, that inline revascularization, getting direct blood flow to the foot, is critical, particularly the more significant the tissue loss. Again, my bias, which I think is supported by many of the studies, is that if there's adequate vein available, and it's not always the ipsilateral vein, not always the same leg vein, but occasionally the contralateral leg or even arm vein, I think that's preferable to endovascular approaches. If somebody has proximal disease, if they have high-grade iliac stenosis or occlusion that you can open endovascularly, I think that's very reasonable. I prefer in situ bypass grafting, but I think reverse saphenous vein is an excellent choice. And honestly, as I tell my residents, it's a venous operation. If you have good venous conduit and you're careful and meticulous in your harvesting or exposure of the vein, and you don't damage the vein, and the vein has not been damaged previously by phlebitis or some other problem, a good conduit can get you into a very, very limited arterial outflow and have excellent results. On the other hand, bad conduit, even a favorable outflow, tends to be less satisfactory and may be a role for prosthetic grafting. I can't emphasize enough the importance for meticulous technique and trying to really limit the trauma to the tissue. I use a tourniquet for my distal anastomosis many times, although if they have heavily calcified vessels, it's not useful, but it allows you to do your distal anastomosis without clamping the tibial vessel, and makes the technical aspect of it much simpler. So I've added some references at the end. Some of the slides have references at the bottom of the slide, and I would encourage you to investigate these. These references are predominantly references from consensus European or American guidelines.
Thank you very much, Dr. Patterson, for your wonderful lecture. And yeah, we would be now just dedicate our time for Q&As, and we have the first hands raised. Dr. Chervonovchenko, please.
Thank you for a lecture. My question may be a little bit off topic, but it's related to other aspects of vascular surgery, I think. After vascular anastomosis, if it's end-to-end or if it's using prosthetic devices, what laboratory values do you monitor, and what are the targeted numbers which you look for?
So ideally, well, it depends a little bit on how you've reconstructed them. Ideally, you'd love to have a palpable pulse at the end of your reconstruction. That's the best. I think what you want is clinically accessible improvement in the perfusion. So if somebody comes in and they have an ankle brachial index of 0.2, and you do a reconstruction to a perineal artery where you don't have good ability to assess a pulse in a perineal artery, for instance, you would at least expect a improvement in the ankle brachial index to greater than, say, 0.8 or so. If it goes from 0.2 to 0.3, you probably have a problem. I find that imaging, duplex imaging of the graft of the entire reconstruction is really helpful, especially in your initial visit, either in the hospital or in the office. If they've done great in the office, if there's any question about a technical problem or inadequacy, a duplex scan, I think, is very helpful in terms of looking for any technical problems that you might encounter. I think that the hemodynamic improvement of a properly planned prosthetic artificial graft should be just the same as a vein graft. Does that answer your question?
Actually, I was asking about, for example, let's say we perform some abdominal surgery with the vascular resection, for example, portocaval anastomosis and so on. I was asking about coagulation profile. Trying to prevent thrombosis of a vascular anastomosis or prosthetic graft. Do you monitor some coagulation values, and what are the targeted numbers?
I don't routinely heparinize my patients after reconstructions, and I don't think that that's generally the standard for portocaval and portomesenteric reconstructions, which in our practices are done predominantly by the hepatobiliary population surgeons. But those grafts tend to be relatively short and sometimes autologous tissue, sometimes prosthetic. I think antiplatelet agents are useful in most vascular reconstructions. But I don't think that in the high flow settings, such as the portomesenteric circulation, I think that the most critical thing is avoiding technical problems with the graft and not being concerned about long-term anticoagulation. If you extrapolate from some new studies in the peripheral circulation, the combination of aspirin and a low-dose novel anticoagulant, rivaroxaban, for instance, has some improvement, and that may translate to the hepatobiliary system, but I don't have experience with that.
Thank you.
Thank you very much. Next question from Sophia.
Good evening. Thanks so much for a great lecture. And my question is your advice for management after grafting, aortic grafting, and how do you choose how to use triple or double antiplatelets and anticoagulate therapy, and how long can we use it?
For aortic grafting, I just use single agents. I don't use dual antiplatelets unless there is another indication such as cerebrovascular disease or a recent coronary stent. But in general, I just use single agent. And aortic grafting, either aorta-iliac grafting or aorta-bifemoral grafting, postoperative management, you mean after discharge, after their recovery? Or
yes.
Yeah.
After operation.
Yeah, I see them early in the post-op period for wound checks and make sure that their result is what it should be. Do I have what I would expect to be as far as their examination? Do they have proper pulses? Are they recovering properly? So I usually see them about a week or two after discharge. I see them at 3 months after discharge, and then if the reconstruction is satisfactory, and we tend to evaluate that with ultrasound. If I'm happy with the revascularization, I see them annually. And again, adherence to the medical principles that I outlined at the first part.
Is it the same treatment in elderly patients?
I don't look at age as much as I look at physiologic age. So I have patients in their 50s who I think are extremely high risk, and I follow them more carefully because of that. And I have elderly patients in their 80s and 90s who are very robust and very healthy, and I don't take that as necessarily a factor. Does that help?
Yes, thank you.
Okay.
Thanks, Dr. Patterson. Next question from Markian.
Good evening. Thanks for the great lecture. I'm sorry, maybe this question is not directly related to you as a vascular surgeon, but the current literature says that there is no difference between hand-sewn or staple anastomosis. But I found some articles about the acute mesenteric ischemia and anastomosis after the vascular procedures, and the article says that the hand-sewn anastomosis is better. Do you have any opinion on that?
So I'm a trained general surgeon, but I haven't done general surgery for years. What I'll say is that I so seldom see my general surgery colleagues do a hand-sewn anastomosis, even after a resection for ischemia, that it doesn't appear to be our current practice. I'm not familiar with the literature. I'm old school. I trained with hand-sewn repairs, but I can tell you that looking at the approach of my current colleagues, I don't see that as a standard.
Thanks.
Thank you. Next question from Alexander Boyarsky.
Good evening. Thank you for the great lecture. In the case of open repair of aortic aneurysm and the presence of abdominal infection, are there any specific recommendations to decrease postoperative morbidity?
So, let me understand this a little bit better. In what setting would you see an open aneurysm repair in the setting of a intra-abdominal infection?
No, in the case of ruptured.
Yeah. So, there's doing a repair with autologous tissue, taking deep veins and making a new aorta is such a challenging operation that for somebody who comes in who's unstable, it wouldn't be considered an appropriate approach. That approach, using the deep veins of the leg to reconstruct the aorta is a consideration for somebody who comes in with an infected aorta or an infected graft. But in a setting such as you suggest, I wouldn't consider that. In a patient that has other infection, you would deal with the infection first, if possible. If it's a rupture, you would at least get vascular control, but you want to debride and get things cleaned up as much as you can. And again, in an emergency setting, probably the best you can do is soaking a graft with rifampin prior to reconstruction. The availability of things like cryograft and stuff in an emergency setting is pretty rare. And actually, the long-term performance for infection of a cryograft or an antibiotic soak graft seem to be similar, different morbidities from the two, but similar in their outcomes. And then finally, if you really have a horribly contaminated situation, isolating the diseased aorta and occluding it and clamping it, and then doing an emergency axial bifemoral graft could be a very reasonable way to keep out of trouble with infection. A daunting operation, but with two surgeons, you can accomplish that relatively quickly. And again, if you're really concerned about contamination, that's one consideration. But if you think you can get everything controlled and cleaned up prior to revascularization, soaking a graft and then making sure there's excellent coverage of the graft with retroperitoneal tissue is the appropriate approach.
Thank you.
Thanks, Dr. Patterson. Next question from Georgi Ismailov.
Thank you for the lecture. My question is, if abdominal aorta aneurysm involves renal arteries, what should you do with them after the repair? Do you reimplant them in the graft or above the graft, or what is treatment in that scenario?
So I individualize those. Occasionally, what you can do is to taper the proximal portion of your graft. So you have a clamp, either suprarenal or supramesenteric, but you can taper the graft so that you can incorporate one of the arteries in your proximal anastomosis, possibly. Okay, if the aneurysm, if the diseased aorta allows that, that's a very useful way, and then you can reimplant the other one. That's a nice way to take care of one that involves the renal arteries, maybe just above the renals on one side, but allows you to, a little bit more expeditiously to get flow to at least one artery. On the other hand, if the aneurysm is clearly above the renals and your proximal anastomosis cannot incorporate any of the renal artery orifices, then what I try to do is to establish my graft with side branches that I put on the graft before I start my reconstruction, and then do your aortic reconstruction, and then reanastomose your two renal arteries to your side branches. It's useful in that setting to have iced perfusate with a balanced solution like Normasol or Plasmolite, something that is pH balanced, with some heparin and maybe a little mannitol in it, and perfuse the renal arteries while you're doing your reconstructions. And that gives you a little bit more time for permitted renal ischemia, like the transplant patient service uses.
Mm. Thank you.
Thank you, Dr. Patterson. Another question from Sophia.
If the patient don't have saphenous veins because he undergoes to prostatectomy and venectomy on both legs, what type of harvesting, which vein we can use for shunting?
Okay, so sometimes the saphenous veins, I mean the lesser saphenous vein.
Not laser, classical operation, prostatectomy and venectomy.
Yeah, so both the greater and the lesser saphenous veins are not available.
Yes, yes.
Yeah, I assess the arm vein and use that, do a duplex scan with a Penrose tourniquet at the upper arm to assess those veins, and you frequently can get segments of the vein either using the deep basilic vein or the cephalic vein to get adequate conduit. Sometimes you just can't. You know, that's the unfortunate situation, is sometimes that's not available. But in at least here, most of the venectomies that are done are approach the greater saphenous vein. There's often lesser saphenous, or they've been harvested, or the saphenous vein's been harvested for coronary bypass, or they've had a phlebitis in the past. If they have adequate lesser saphenous vein, I'll put the patient prone, harvest both saphenous veins, and then flip them over and do their bypass. I find that the most efficient way. If not, I isolate the arm and then start my dissection down at the level of the wrist in the snuff box, and then follow the vein with a continuous incision using scissors to track the vein. And having done an ultrasound, you can map out the area where the vein you're going to use.
Thank you so much.
Sure.
Thank you. Another question from Victor.
If a patient is on antiplatelet agents and we wanted to put them on venous thromboprophylaxis, for example, on low molecular weight heparin, should we discontinue antiplatelet agents, or should we reduce low molecular weight heparin dosage? What would you advise in such scenario?
For DVT prophylaxis, I would add the low molecular weight heparin, but I would not change the antiplatelet regimen long term. A lot of times antiplatelet regimens are interrupted during hospitalization because patients are NPO and we don't want to use rectal aspirin or something. But I think that I don't think DVT prophylaxis needs to change your antiplatelet management. I don't think the increased bleeding from that is substantial. Now, if you're using full dose Lovenox, even then, I think that we have plenty of patients that we maintain on formal anticoagulation and low dose antiplatelet agents. I think the difficulty gets into patients who are on dual antiplatelet agents for some reason, such as a coronary stent, that come in with the DVT, and then you're facing 3 levels of anticoagulation, and they're at greatest risk. So perioperatively, I think that it's appropriate to do your prophylaxis with low-dose heparin. The other option is sequential compression stockings instead, which in many series have been just as effective as low-dose heparin with a lesser bleeding side effect.
Thank you.
Thank you very much, Dr. Patterson, for this amazing lecture and for answering all these questions. Using the opportunity, I just wanted to remind to our participants that Dr. Patterson is already a user of HealUA mobile application, so if you will have any questions regarding the vascular surgery, please feel free to ask there. You know that we have translating services, but if you are available, please ask questions in English directly. So, Dr. Patterson, thank you very much again.
Well, thank you for the opportunity. I appreciate the questions, and I hope I've been of some help.
Thank you.
Thank you. Bye-bye.